Assalamu alaikum, everyone. My name is Dr. Yasir Khan, and among many other jobs today, I'm here to discuss the tips and tricks when you're planning for your MPFL reconstruction. And before I start, I want to thank me for inviting me to the knee meeting. So I have nothing to declare. So I started my career as a young aspiring surgeon from Ireland. I did all my basic and higher surgical training from there. I never won the beauty award, but I know, and those of you who have visited know that Ireland is a beautiful place. From there on, I jumped from different continents, so I've moved back to Pakistan recently, almost 2 years ago. So anyone who wants to do sports medicine should remember this face. This is Dr. Houston. He's the forefather of sports medicine. To his credit are numerous books, chapters, and case series and articles. And he is the one, in his lecture in 1968, pointed out subluxation of the patella. And that was a major turning point in the history. And that's what we are here now because of this paper and how we manage knee injuries today. Right, so for many years, we never knew where actually MPFL was because it was hidden. And it was hidden between the fibrous connections among the layers on the medial side of the knee. And only recently, after years of work, we now know that it's in the second layer on the medial structures of the knee, and it's mainly extracapsular. It is a fan-shaped, where 1/3 of it is attached to vastus intermedius, and 2/3 along the upper border of the medial part of the patella. Now that's the easy part. The tail goes to somewhere between adductor tubercle and the medial epicondyle of the femur. And that's where the problem is, because we never knew where exactly that point is located. And our earlier reconstructions until now, if you're not careful, the major cause of MPFL reconstruction is because of femoral tunnel malpositioning. And this is the point. Published 2007 by Shull, and he identified that point to us, and we must be very thankful to him. So you need to draw a line along the posterior cortex of the femur, and it is located 1 millimeter above that point, 2.5 millimeter to the most posterior part of the Blumenset line, and 2.5 millimeter distal to the posterior origin of the medial femoral condyle. Still very confusing, right? But this is where I want you to pay attention. A lot of studies after the initial paper from Dr. Houston was done on the biomechanics of the patellofemoral joint, and we know that it is a complex coordination of static and dynamic stabilizers. And the major role of MPFL is from 0 to 30 degrees of flexion, because from there on, it's the trochlear groove that captures the patella and adds to the stability of the patellofemoral joint. So real problem is really from 0 to 30 degrees. We don't have any gold standard as how to reconstruct. Various people, various surgeons have tried many different techniques with different tendons, including gracilis, semitendinosus, iliotibial band, adductor longus, single, double-stranded, with bone tunnels or soft tissues and different type of fixation materials, including sutures, anchors, screws, and endo button. So there is no gold standard. But before you go into that, we also need to consider, are we doing an isolated MPFL reconstruction, or do we need to do any concomitant procedure along with that? So if you are doing an isolated, and this is the first step, by the way, guys. If you want to do an isolated MPFL reconstruction, you need to make sure that the patient doesn't have any sort of patella alta. So use the scores, do your history and examination properly, get your MRIs and X-rays, and measure that there is no patella alta. Next, we know from the biomechanical study is the role of the trochlear groove from 30 degree onwards. So you want to make sure that there is no trochlear dysplasia. And if there is, it should not be more than type A, which is a bit of shallow trochlea. So anything beyond that means you need any other concomitant procedures. And the last and the most important thing is that if the dislocated patella is there for long, the lateral structures are not contracted. And I will tell you later on why, that the lateral structures should not be too tight. Because you need to remember, what you are doing in this scenario is not pulling the patella back into place. You want to keep the patella, your reconstruction, to help the patella to stay in a place against excessive force, okay? So you're not pulling it. You're not trying to bring it down with your reconstruction. So when you start, it is always ideal to do a diagnostic arthroscopy. You check the patella movement and see if there is any loose bodies. And if there is, you need to remove it. If there's any other intra-articular pathology, you need to deal with it. And also see the cartilage itself on the patellar side and document if there is any damage. Next step in the procedure is graft harvesting. I tend to do with semitendinosus or gracilis. Sometimes I'm confused which graft I've taken. It's not easy always to know which one. But ideally, it should be gracilis because that mimics very closely to your MPFL. And the ideal length you need of your graft is 180 millimeter or 18 centimeter. The next stage is where you can, save yourself and blame your assistant, okay? Because it's now your assistant role to help you. You need to have a true lateral. Your assistant need to hold the leg so it's not wobbly. Your II is right in the true lateral plane, and you need to open up the medial side, clean up the upper 2/3 of the patella, stabilize it. There are now different drill guides and pins available you can use. If there is none, you always have an ACL drill guide, which sometimes I use, so you can put your ACL guide and stabilize your patella against it, and you need to pin 2 pins. The next step, those 2 pins should be 15 millimeter apart, okay? So there are guides available that help you just, 2 parallel pins 15 millimeter apart. If you don't, you're doing it, freehand, make sure it is 15 millimeter apart. This is where I want you to spend more time. Take your time, get your assistant to stabilize his hand, tell him to have some coffee or sugary drink so he doesn't really go during the procedure, because this is where you need to spend time. Identify the shuttle point, okay? True lateral, in position of the knee, you need to identify it. You are allowed to have a 5 millimeter variation. Anything more than that, you're bound to fail. Okay, so make sure that this is where you need to go in. The next tension is how to maintain the tension or minimize or maximize the tension in order for your MPFL to work. The one tip is that once you have your guide pin inserted at the shuttle point and your grafts are there on the patellar side, you can loop that graft around the pin and do some cyclical loading, flexion, extension, okay, until you are happy regarding the movements of your patellofemoral joint, the alignment. Okay, this is one tip you can do. The other thing is that once your tension, you're happy, you ask your assistant to hold that tension and you can check it manually. It should not displace 30 to 40% of its transverse diameter. Once you're happy, you fix that graft with the knee in 30-degree flexion. A follow-up, once you're done, is your checkmate. You know you have done the job well. You look at the joint, you look at the alignment, and this is where your kind of reconstruction looks like, a tight band on the medial side. A few years ago, it was actually contraindicated to reconstruct MPFL in adolescent patients with open physis. However, it is now possible, okay? You can do a basket weaver, which is completely soft tissue procedure. And if you have to put an implant, this is the tip. Your guide wire for the screw for your femoral implant needs to be slightly directed towards inferior and medial, towards the intercondylar area, just to avoid the physis. Once you're done, your road to recovery starts. You put the patient in an extension brace for 1 week. Some would agree, some would not. But then you can gradually bring the patient, work on the rehab and then strengthening. And recommended is that you allow, if it's a professional athlete, to be back playing sports in around 9 months' time. So in conclusion, identify your instability factors, your patella alta, tight lateral side, no trochlear dysplasia. Take your time, identify the shuttle point. Remember, there should be no pull from your reconstruction, okay? And beware of open physis. Thank you and welcome to Karachi.